Hi, I'm Michael Field. I'm a clinical cardiac electrophysiologist in Charleston, South Carolina.
Hi, I'm Dr. Barbara Wiggins. I'm a clinical pharmacy specialist in cardiology.
Barb, thank you so much for being here. We're going to talk today about drug-drug interactions as they pertain to the direct oral anticoagulants, or DOACs. And you've had extensive experience as a clinical pharmacist in cardiology and have also published a number of manuscripts about drug-drug interactions with cardiovascular medicines. So we're really excited to have you today and hope to learn more about this important topic.
Thank you, Dr. Field. Yes, this is coming up on my 25th, almost 25th clinical year in cardiology. And, drug-drug interactions are something I've become very passionate about over the years as a result of patients being admitted to the hospital for what are seemingly adverse reactions and adverse effects of a medication, but actually were precipitated by the fact that the drugs were combined. And so, I started on this journey a few years ago with a couple of publications, and the DOACs have really come to the forefront of this, in part because of their popularity in prescribing, but also because of the risks involved when these drugs, the concentration of these medications actually could potentially rise as a result of a drug interaction and potentially increase potential bleeding risk for patients. So it's great to be here, and I'm looking forward to our discussion.
I think this is a really important and interesting topic for clinicians to learn more about. Many of us work through the days of anticoagulation using vitamin K antagonists like warfarin, and we're certainly well aware of all the different drug interactions. It was part of a daily routine. Any new medication, we had to be aware of, the potential for the INR levels to change. Now that the direct oral anticoagulants, or DOACs, have made it to market, it's really changed our practice in so many positive ways. But I also understand that there are a number of important drug interactions that people need to be aware of. And I think sometimes for clinicians now, because it is so much easier to use these drugs, we often lose sight of some of the important drug interactions that can be out there. So we look forward to hearing more from you about what these are. I feel like, just to kick us off, what is the importance of the drug interactions, and why is this a topic worth discussing?
Well, I think, drug interactions are probably one of the biggest challenges for healthcare providers. We have a lot of medical alerts that pop up in our EMRs today. And I think the challenge is, how do you really how do you quantify the drug interactions? And when, the FDA requires certain drug interactions to be conducted before a drug is approved, but the challenge is it's a limited number of medications. And so when a drug first comes out on the market, we don't know a lot about it other than how that particular agent is metabolized. And so when you're trying to evaluate everything, it becomes very, very challenging, because those few drugs that are evaluated for an interaction are not necessarily able to be extrapolated to the mass of medications, even within the same class that those medications fall. And recognizing those limitations really puts a big onus on the healthcare provider to be able to sort of interpret what I'm supposed to do in a given situation when a drug interaction alert occurs. And it's very, very complicated, because you have multiple mechanisms in play. You have what most everyone's familiar with is a cytochrome P450-3A4, but you have other mechanisms, and if they are affected by multiple mechanisms and multiple medications, it creates even a bigger problem. Now, we do get, after medications have been out for a while, we'll see pharmacokinetic studies that have been done, or some that were done in development, and that's helpful. But there are a lot of limitations from those studies as well. They're a relatively small number of patients. So when I say small, I mean single digits to maybe 10, 12 patients. Those are also healthy volunteers, not patients with comorbidities, and not patients on multiple medications. Those two medications are being evaluated sort of in a silo. And so what we see from that interaction is really the best case scenario, and have to recognize that we would have to sort of make it more pronounced in someone who may have other issues, such as end organ dysfunction, et cetera, that would make it potentially even worse. So that's sort of the complexity of it. And it just continues to be problematic throughout clinical practice.
What are the most common mechanisms of drug-drug interactions with the DOACs?
Well, I think probably the most common ones is the 3A4, and you also have P-glycoprotein in play. So for dabigatran, for example, you have P-glycoprotein. For 3A4, you have your rivaroxaban, apixaban, and and it isn't just simple as saying this one's 3A4, this is P-glycoprotein, because even between the DOACs, one relies on 3A4 more for metabolism than another. So the significance of one set drug interaction may be more severe with one of those agents versus another one. And so that's where it gets even more sort of intricate with regard to drug interactions. So for example, we have some pharmacokinetic data with rivaroxaban and amiodarone. And what we know is that when the creatinine clearance is slightly low, so moderate, less than 80, but greater than, 50, there's about a 1.86-fold increase in rivaroxaban concentrations when combined with amiodarone. And so, anytime you increase the level of an anticoagulant, your biggest concern is going to be bleed risk. Couple that with a patient that may have had a fresh stent, is on aspirin or a P2Y12 or both and all three, then it just manifests like even more. So if you may argue that if you see a 1.86, almost twofold increase, well, could I just reduce the dose? Well, maybe you could, but I think that the better part or the better clinical judgment might be to maybe try to find a DOAC that isn't going to interact as significantly, to try to reduce that risk as much as you can. But again, the biggest challenge is a limitation of data to help us quantify these. Quantifying it helps you be able to make a more well-informed decision.
Let's talk specifically. You mentioned amiodarone and rivaroxaban. For the practicing clinician, what are some of the big drug interactions that they need to be aware of with regards to, for example, the antiarrhythmic drugs, the calcium channel blockers, or other classes? What are the ones that you want people, after hearing this session, to kind of take home and remember?
So I think, some of the bigger ones are those agents, your select cardiovascular agents that are metabolized by 3A4 or rely on 3A4. So you're going to be dealing with drugs like verapamil, diltiazem, amiodarone, dronedarone. Those are kind of sort of your bigger ones to be aware of. Amiodarone is well known to have a lot of drug interactions. And, when you combine it with a DOAC, there's always that risk as well. But obviously, some of those are going to vary. The severity is going to vary depending on other drugs that they're on. Renal insufficiency, or renal function also compounds that. So, it's best to really become very familiar with certain agents, such as whatever DOAC you feel is best for your patients or whichever one you're most comfortable with, and really know the drug interactions that are affected by that particular, or that affect that particular DOAC. And then when you've hit a roadblock or a potential concern, let me go look at this other one and see if it also has the same issues. So, we have to do that for a multitude of classes of medications, right? We do it for the P2Y12s. We kind of tease out which one we're going to choose for the most of our patients. And I think you kind of go down that same path with the DOACs as well. Which one appears to have the least amount of drug interaction concern for the patients that I'm seeing? And I think that's where you start, but recognize you may have to switch gears to a different agent if need be.
A lot of the clinicians are aware of drug interactions that are affected through inhibition of the 3A4 pathway, which results in, for example, higher levels potentially of the DOAC in the patient. Similarly with the GP, drug interactions. Tell us a little more about inducers and how that might be important. I think a lot of clinicians aren't as aware of the relevance of certain drug interactions that have to do with drugs that are inducers?
So the inducers actually are problematic for even Coumadin. So they include the DOACs as well as Coumadin. The main difference is that Coumadin you can monitor INR. And so you can modify and adjust your dosing based on that induction. So essentially an induction is going to accelerate metabolism, result in reduced levels of the anticoagulation potential increase in thromboembolic risk. And I think probably some of the highlights with medications that fall into that category include phenytoin, include primidone, and phenobarbital. Well, though phenobarbital is not, quote, used that much, primidone is actually metabolized to phenobarbital. So there's a significant concern that you're going to have reduced efficacy from a DOAC when combined with primidone. So you have to be very careful. St. John's wort is an over-the-counter option. A lot of patients take St. John's wort. It's also known to be an inducer. So that's something that clinicians should also be aware of. We don't have a lot of data, but what we do know is it is an inducer. And in terms of trying to be optimally safe for patients, it's likely best that they not continue taking it.
Well, that's helpful, Barb. Let's shift gears a little bit to COVID-19 and the drug Paxlovid. I know a lot of people have now, as you know, as they practice, gotten messages from patients or notifications that the patient has COVID-19. They want to start Paxlovid as oral treatment. And there are just so many different drug-drug interactions with this new agent. Just, if you wouldn't mind, just give an overview. Why is there such an important, or why is Paxlovid associated with so many drug-drug interactions?
So Paxlovid is a combination product of nirmatrelvir as well as ritonavir. And ritonavir is very well known to be an inhibitor of 3A4, and it's added to this agent as a boosting agent in order to minimize its metabolism to increase efficacy. And so because it is such a strong inhibitor of 3A4, it is going to have a high propensity to cause a lot of drug interactions. And so that's probably one of the biggest issues that we're facing. And so with regard to data, it's sparse. Most of the drugs or medications that we use from a cardiovascular perspective, many of them are not studied in combination with Paxlovid. So it really is unknown territory. And a lot of the recommendations that you see out there are really drawn from the interaction of the 3A4 and how that particular Paxlovid is metabolized and how the medication that you're using is metabolized and how that interplay will unfold potentially in a clinical setting. So that's how that sort of pans out with regard to Paxlovid. And there are a lot of significant drug interactions from a cardiovascular perspective with this combination product.
What is a practical way for a clinician taking care of a patient who's being asked to contemplate whether or not it's safe to start Paxlovid and looking through all their drugs that they're on, you know, kind of what's an overview or general approach that works or that people can take home to try to understand how they might approach that subject?
Well, I think there's a lot of things to take into consideration. I think, you know, first of all, has the patient had prior COVID infection? Have they been vaccinated? What is their overall risk? What is their age? What's their renal function? All of those are sort of patient-specific parameters to be taken into consideration. And then also you have to think about the medication that is interacting with the Paxlovid. So, you know, many of these recommendations are to hold the select cardiovascular agent, such as a DOAC or an antiarrhythmic, but that may obviously not always be feasible. So, you know, for a drug like dofetilide, which requires hospitalization for initiation and continuation, that's not something that you necessarily want to discontinue. So when discontinuation is prohibitive, I think the obvious thing to do is to either look for an alternative agent to Paxlovid, or you just unfortunately have to forego treatment from that perspective. Now, there are some varying recommendations with some of the DOACs out there that you may see. they anywhere from holding it, again, depending on risk. And some will recommend perhaps a dose reduction, specifically with apixaban, for example. But again, I think we have to be careful in that that was evaluated in HIV patients. It's a small number of patients. If you have the ability to monitor apixaban levels, that may be a feasible option. But I think in the absence of that, we just don't know the extent of the interaction and how much of an exposure would be increased to say as a general guidance that that is okay to do and acceptable to do in all cases. I really think in general, all of these have to be individualized.
Yeah, thank you. And we'll include with this session some references at the bottom, and you've published a guidance document that I think will be helpful for clinicians as a review of the various cardiovascular meds, how they might interact with Paxlovid, and then kind of a framework of how to, approach that. I think that's going to be a helpful reference.
So Dr. Phil, one of the main things and one of the reasons why myself and many of my colleagues put many of these resources together was to inform and to highlight the importance of being aware of drug interactions and hopefully being able to provide some level of guidance on how to manage them, but realizing that, as I said before, it's going to have to be very individualized based on the patient-specific parameters and overall risks involved, and obviously the medications that you're trying to combine and adjust for a given patient. But it is difficult because lack of data and EMRs don't always quantify because we may not be able to. So I think from a provider perspective, I would like to sort of get your insight and sort of give me a sense of how you go about evaluating this when you see it in your practice every single day. What is sort of your walkthrough of how you evaluate this, and what do you think would be helpful going forward?
Yeah. So, I mean, that's an excellent question. I think first and foremost, it's just an awareness that there are important drug-drug interactions with the DOACs. It's become all too easy to just prescribe the drugs, figure out what you think the dosing should be based on certain patient-specific parameters, but really not pay attention to all the other drugs the patient's on. And just having that awareness first and foremost, I think goes a long way. Like you brought up, there's a lot of alert fatigue when it comes to the electronic medical record, or even some of the programs that we can use on our smartphone that do alert us to the presence of a drug interaction, but don't really help us understand, is it something that's very minor or something that's more significant that we really have to be concerned about? And, I think that's where having a collaborative relationship with a pharmacist is really important. There's opportunities, I think, on the outpatient side to have a relationship with a pharmacist. I've seen a lot of health systems incorporate their previous clinical pharmacists that have been involved in, vitamin K antagonist monitoring, warfarin INR monitoring, and adding to that clinic, the ability to monitor or educate patients about DOACs. And those have been extremely helpful in our health system. On the inpatient side, interdisciplinary rounding to help catch drug interactions, avoid errors and really help with the dosing has been really important. And then we alluded to a little bit earlier, some of the guidance documents out there. You've done a great job of collaborating and publishing, very practical, hands-on documents that can be referenced. And we'll include some of those at the end of this session for clinicians to look up. But I think those provide the level of granularity and detail that we need, and they can look a little deeper. But even just having the charts and understanding kind of what the drugs are that interact with the various DOACs that we might use, can be helpful. And I think they also are worth a read because it really highlights, like you alluded to earlier, the fact that a lot of these recommendations or guidance really is based on some limited or incomplete data. And we really have to, take into account all the complexities of, individual patients and their comorbidities. And so I think, lastly, just good clinical judgment and trying to really understand, is this the right drug? Are there other options? What are the individual patient bleeding risks versus stroke risk, and kind of go from there.
Yeah, no, I appreciate that. And I think, one other thought on this is that, and I know it seems intuitive, but and you sort of touched on this, was when we have pharmacists in an anticoagulation clinic setting, and that is reviewing the patient's medication profile and looking at all the medications they're on, and stressing to patients the importance of utilizing one pharmacy and of getting all their medications from a single source so that they can minimize the risks of a significant drug-drug interaction. Because medications are being prescribed by different providers, it's not always as easy as, just, oh, let me look at this and see if I can find it. It's not that simple, because they may have received a prescription that you are completely unaware of, but that pharmacy can certainly catch it on the very back end and potentially avoid something very serious. So, again, I think shared information with the patients, and them recognizing the importance that having a sole source of medications is so vitally important as well, to help everyone be able to optimize patient care, but minimize the risk as well.
Yeah, well, that's great. I really appreciate your time. It's been really informative for me. And again, thank you so much for the information and what you do.
Thank you, Dr. Phil.